Hi, Dr.
Hello,
Devika.
hi.
Hi.
Yeah, wait, okay. Am I lagging?
You are how to say
Your
vertical,
camera
not
orientation.
horizontal.
Yeah.
I don't know how to change the orientation. Ah, how? No need to change. Can I just hide self view?
You're using your laptop or phone?
I'm using laptop, Dr. Tong.
Oh, I I don't know. I'm not good at this also.
Okay.
Dr. Kelvin, you know how to help her?
Wait, hold on.
I don't know. Sorry, Dr. Tong, I might ended up coughing and sneezing along the way. I'm not well.
It's okay.
Hello, hi Dr. Devika.
Yeah.
Afiq here from College Physician.
Yes.
So for your video rotation, you can go
Ah.
to the start video, right? And then there's a up.
Start video. I
yeah.
can only see stop video.
Stop video there. There's a arrow up there, right? There's an arrow.
Select a camera, FaceTime
Then
HD camera,
video setting.
video setting, okay?
So when you go to the video setting,
Oh, okay.
icon that, yeah, that one.
Okay. Can it?
Yes, yes. Now
Okay.
correct.
Thank you, Doctor.
Thank
I
you.
think while waiting for Dr. Devika to prepare her slide, I'll just introduce all of us to our chairperson today. So, good afternoon, everyone. Welcome to our weekly webinar organized by the College of Physicians Malaysia. Theme of the month is endocrinology, and with us today as our chairperson is Dr. Tong Chin Woon. A few words on Dr. Tong. She attained her MD from UKN, followed by MRCP and FRCP from Royal College of Physicians, London. She completed her endocrinology fellowship with Ministry of Health Malaysia in 2015 and is now practicing in Putrajaya Hospital. She is actively involved in research and publications, and her special interests include type 1 diabetes, diabetes in youth, and adrenal disorders. Without further ado, let us welcome Dr. Tong.
Hello. Good afternoon, everyone. Welcome to this endocrinology series of webinar. So I guess you're expecting Dr. Azrai to be chairing the session today, but yeah, I've taken his place instead because he's busy with a meeting. I hope that's okay with everyone. It's a great pleasure for me today to introduce our speaker, Dr. Devika Lachmanan, who is a physician and endocrinologist in Hospital Port Dickson, Negeri Sembilan. So I just realized today that we graduated from the same university, Devika. So that's nice to know. And Devika is apart from being a clinician, she's also actively teaching in IMU as well as in UCSI University. And she has a keen interest in research and publication. I can see her list is getting longer and longer. And she is here to talk to us today on the topic of Cushing's disease and syndrome management. So I'm sure we are all very excited to hear from Dr. Devika about Cushing's disease and syndrome. So, Dr. Devika, the floor is yours.
Thank you, Dr. Tong, for the kind introduction. I shall share my screen now. Can you all see my screen? I'll put in the PowerPoint.
Yes, can
Yeah,
see.
yes.
Okay. Hello and good afternoon, everyone. Thank you, Dr. Tong, for the kind introduction. And thank you for the opportunity as well. And I'm very grateful for all the attendees for taking time to attend the webinar today. So let's start with case presentation. I have 3 cases to share with you all. So the first case being a Madam A, a 69-year-old lady presented with progressive weight gain with proximal muscle weakness. And she has underlying poorly controlled type 2 diabetes with the A1C of 11.2% on maximal OAD and basal bolus insulin. She has hypertension in which she's on single antihypertensive agent. And physical examination noted to have central obesity, purplish striae over the abdomen and axilla. She has thin skin with easy bruising. She was actually admitted to another center for pneumonia recently and noted to have persistent hypokalemia. She was referred to me for further workup of hypokalemia. Sorry. Okay. So let's look at the case number 2. This is a Miss Uzet, a 16-year-old. She's rather young, very young, presented with progressive weight gain with a deepening of voice and excessive facial hair. The medical history will be she has newly diagnosed type 2 diabetes with hypertension and morbid obesity with stunted growth. She's merely 140 cm in height. And physical examination revealed central obesity. There's a purplish striae over the abdomen and axilla. She has acne with facial plethora, proximal myopathy with a supraclavicular fullness and dorsal cervical harm. She was referred for further workup of secondary amenorrhea. Moving on to case number 3, this is a 30-year-old Miss CS. She presented with progressive weight gain, acne, hyperpigmentation, and irregular menses in a very short duration of period, is about months. She has newly diagnosed type 2 diabetes together with hypertension. Clinically, she noted to have central obesity, purplish striae over the abdomen and axilla, acne with facial plethora, proximal myopathy, and hirsutism. She was actually referred for suspected Cushing syndrome. So what are the possible diagnoses? So let's think about the possible diagnosis and we'll come at the end of presentation for the answers. Today, I was given a task to talk on Cushing syndrome, focusing on Cushing disease. It's a rather a wide topic, and I can assure you, no one can cover about Cushing syndrome in 1 hour, everything. I've tried my level best to cover as much as possible, and I understand today the attendees with from different background, from houseman to all the way to consultant, some are in the hospital setting and some from the KK setting. I hope today's presentation is neither too simple nor too complex. Before we look into this Cushing syndrome, come let's revise on our hypothalamic pituitary adrenal axis. So this is back to our physiology. Hypothalamus produces corticotrophin releasing hormone in which it works at an anterior pituitary gland, producing adenocorticotrophic hormone. This ACTH subsequently works at adrenal gland, resulting in production of cortisol from glomerula fasciculata. The cortisol level in our body is always maintained in check. So when there is an excessive cortisol production, so the body will send a negative feedback to the hypothalamus as well as the pituitary gland to reduce or to shut the further CRH and ACTH production so that the cortisol can come back to net value. Okay, so what is Cushing syndrome? It's a disorder from chronic exposure to excessive cortisol in the body. It can be from exogenous source, which is the most often of time, and to a small entity, it can be from endogenous production. So when it comes to endogenous Cushing syndrome, it can be further divided whether it's a ACTH dependent or ACTH independent Cushing syndrome. When we talk about ACTH dependent, we are either dealing with a pituitary source or it could come from ectopic sources. When we have ACTH independent Cushing syndrome, this is always from the adrenal gland. So what is Cushing disease? So it is the most common cause of endogenous Cushing syndrome. It is caused by an ACTH secreting pituitary tumor. So let's look at this diagram here. Cushing syndrome versus Cushing disease. Is this interchangeable? We can just use the term as what we wish for. So this is not the same. Cushing syndrome is basically a disorder due to excess cortisol in the body. If the excess cortisol is from the pituitary source, and then we label as Cushing disease. Only if it comes from pituitary, then we say this is a Cushing disease. I hope from now onwards, you all know the difference between Cushing syndrome and Cushing disease. So diagnosis of Cushing disease is often delayed. It can be years because of the nature of the disease itself. It rather insidious, progressive, and the complexity in diagnosing and screening tools. So it all makes it, there is a delay in achieving a diagnosis. And 90% of time, we see a microadenoma, which is less than 1 cm tumor. And most often, 30 to 40% of the time, we are not able to visualize any tumor in an MRI. It's a disease involving multi-organ abnormalities, resulting in high morbidity and mortality with significant reduction in health-related quality of life. In untreated Cushing disease, the prognosis is rather poor with an estimated 5-year survival of 50%. So let's look at some figures when it comes to Cushing disease. It's rather a very rare tumor. It's rarer than acromegaly. The incidence worldwide being 3.3 per million year and the prevalence being 40 to 60 per million year. How about in Malaysia? I could not find any latest published data. This is, I'm quoting from Dr. Zanaria back in 2019. This is the incidence and prevalence in Malaysia. So this is 30 to 60 cases per year and overall accounting for 1,200 to 1,500 cases. So again, the time taken from diagnosis and the onset of the symptoms, it averages about 6 years. It rather very common in female, about 3 times more common in female than male, and the age of onset is rather young, in 20 to 50 years old. If the Cushing disease is remain untreated, only half of them survives and the other half is actually has high mortality rate. And even if we treat the patient, but the treatment is insufficient, it still has a very high, about 5-fold increased risk in mortality. And most often, the mortality in Cushing disease is due to the cardiovascular disease. It has a handful causes that results in cardiovascular disease, such as your hypertension, visceral obesity, insulin resistance, and dyslipidemia. So what are the clinical issues surrounding Cushing disease? First of all, confirming the diagnosis, subsequently localizing the tumor, then assessing the clinical burden of the tumor, again, managing patient preoperatively, then subjecting patient for surgical option, and what will be the outcome from the surgery, and how do we define cure and remission in this patient's group, and how are we going to evaluate in the event the patient develops recurrence, and finally, how to manage a persistent or recurrent disease, and there are a lot of novel therapies as well. So this is just a lot of papers quoting, quoting different studies which published in the past. What we found is diagnosis is often made late, approximately about 4 years from the onset of hypercortisolism, and it can take up to 12 years after the disease onset. So it carries 4 times higher mortality in patients with uncontrolled disease or in the absence of adequate treatment. What are the determinants to say this patient likely to have a higher mortality if they have persistent disease or age of diagnosis is rather old, or if they have comorbidities such as hypertension and dyslipidemia. You can see quoted from these two authors here, the standardized mortality ratio, those patients with persistent disease, they actually carries about 3 times higher risk for mortality compared to those patients who achieve cure. So this is a meta-analysis published back in 2011, looking at the mortality, morbidity in Cushing disease over 50 years. So this is a small series. They have a 60 patient and 51 were female, and the median age of diagnosis was in the range of 36 and 46, and rather on long follow-up, about 15 years, 13 died and 9 are due to cardiovascular disease. And hypertension, diabetes are associated with worse survival. So you can see here, again, the standardized mortality ratio shows that there is an increased risk when it comes to persistent disease. So what are the diagnostic process of Cushing disease? First of all, we must have a high index of clinical suspicion. Second, we must recognize the potential states of pseudo-Cushing's. Again, we need to know what are the tools to use to screen for endogenous hypercortisolemia and what are the confirmatory tests that are available. Finally, localizing the primary tumor, and finally, not only managing the Cushing disease, but also addressing the multiple comorbidities and complications associated with the disease. So when your patient presents with the overt clinical features of Cushing syndrome, everybody's life is easy. So I'm sure all can pick up the Cushing syndrome, but our life gets more difficult when the presentation is rather subtle. So this is where, as a clinician, we must have a high index of clinical suspicion. When you have someone with poorly controlled diabetes, or they have hypertension with hypokalemia, or when you have osteoporosis in a rather young patient, or those children presenting with stunted growth. So this should ring a bell whether could it be a Cushing syndrome that we are dealing with. So most patients with Cushing syndrome presents with the non-specific symptoms and signs. But however, this could be some discriminatory features, signs and symptoms that when we pick up, we know that the likelihood of patient having Cushing syndrome is very high, such as facial plethora, proximal myopathy, cutaneous striae. We are talking about purplish red striae with more than 1 cm, easy bruising, osteoporosis, and at times they can even present with fracture, weight gain with a decreased growth velocity when it comes to children. So how about the less discriminatory features? They can have central obesity, weight gain, they have type 2 diabetes, hypertension, buffalo hump, supraclavicular fullness, moon phases, acne, hirsutism, fatigue. They can present with mood changes, sleep disorders. They can present with menstrual disorders, or your patient can just admit for recurrent infections or come with poor healing of certain wounds. Or it can be purely an adrenal incidentaloma. So a constellation of features, even if it's mild, should prompt the consideration of diagnosis towards the Cushing syndrome. So I don't have any pictures in my own gallery. So these are the pictures all from internet. So just to illustrate some features that we have already discussed earlier, as what we can see here, this is a typical feature of a moon phases. We can see she's plethoric, can see some acne, and what we can notice is she does have hirsutism. So this is one of the classic features when patient presents with Cushing syndrome. Again, another picture to show that moon phases. Here you can see there is a dorsocervical hump, and here you can see supraclavicular fullness. And again, another picture to say facial plethora, moon phases. And again, this is the typical striae that we are talking about. It's rather purplish and reddish, more than 1 cm in diameter. Please don't only look for at the abdomen. Please look out for the striae at the axilla, upper back, thighs, or gluteal region. Okay, so this is a picture comparing before and after. You can see if the weight gain is rather central adiposity, moon phases, plethoric. Okay, again illustrating the typical striaes. Okay, So we can see from the earlier sign and symptom that a lot of features are overlapping between this Cushing's versus obesity. So this is where we have this table called is a discrimination index. There are some symptoms will yield more probability towards a Cushing syndrome and some yield more towards a probability of obesity. So these are some examples that I've highlighted. You can see when you have osteoporosis, the probability of Cushing syndrome is high compared to obesity and etc. Okay, so what are the algorithm that we use when we have a suspected patients with Cushing syndrome? So when there is a clinical suspicion for Cushing syndrome, so first of all, we need to go back to patient and get a thorough history. So most of the time is due to exogenous steroid. So patient either will be taking any steroids given for whatever reasons. It can be from oral, IV preparation, or intra-articular preparation, or patient can be taking some over-the-counter medications or supplements. If the patient has significant exogenous glucocorticoids abuse, then you're supposed to stop the medicine and reassess the symptoms periodically. Having a negative history for exogenous Cushing's, then there's a likelihood of whether you are dealing with endogenous Cushing syndrome. So when the the likelihood is low, then we proceed with the one screening test. When the probability is intermediate or high, you're supposed to proceed with 2 or 3 screening tests. So what are the diagnostic tools or tests available or screening tests available when it comes to Cushing syndrome? So we have 24-hour urinary free cortisol, we have late night salivary cortisol, we have serum cortisol following 1 milligram overnight dexamethasone suppression test or 48-hour low dose dexamethasone suppression test. There are multiple assays available for these screening tools. So it's essential for us to know what is the performance of the assay that we are using before we subject the patient for that screening test. So when you have screening tests, okay, we'll come back to this test. Okay, so these are the tests that I mentioned just now. So we will go into individual tests in a while. So what happens is when you have the screening test, and if it's negative, then you know Cushing syndrome is less likely, or when there is a likelihood of intermediate or high probability of Cushing syndrome, you must ask yourself, could it be a cyclical Cushing syndrome? Okay, when you get an abnormal result from the screening, you are supposed to repeat other tests to increase the sensitivity and specificity of the Cushing syndrome. So before we proceed further for any localization test, we must establish a true hypercortisolism. Okay, so looking at the individual test, let's talk about 24-hour urine-free cortisol. It must be collected at 2 occasions to enhance the sensitivity. It's a very sensitive test, but it can be cumbersome, especially when you are dealing with pediatric population. And the test relies on accurate collection by the patient. You just have to take patient's word. If they say they have collected for 24 hours, then it is 24 hours. So, however, this test, the cortisol production in the urine is independent of your cortisol binding globulin changes and dexamethasone metabolism and compliance. So when you have a results more than 3 times upper limit of normal, then it establishes the diagnosis of Cushing syndrome. But you can get false negative and false positive results from 24-hour urine-free cortisol. And if you have patients with renal impairment, the urinary collection might be suboptimal, hence resulting in less urinary free cortisol. On contrary, if you have patients with polyuria with a urine volume of more than 5 liter, the cortisol level can be raised. And if we decided to collect in the inpatient setting when patient is admitted for some other reason, stress alone can cause modest elevation in the free cortisol. And some drugs actually can falsely elevate cortisol due to the cross-reactivity with the assay. So when you have a clinical suspicion high and the urine-free cortisol is non-diagnostic, so it's better to proceed with other screening tests. So let's talk about low-dose dexamethasone suppression test. This test exploits the loss of the sensitivity to glucocorticoid feedback. The test is either performed overnight with 1 milligram or performed over 48 hours with 2 milligram. There can be a false positive result. Anything that interferes with the absorption of dexamethasone can result with false negative or false positive results. So it used to be whenever we measure the cortisol, we used to measure the dexamethasone level as well in order to reduce the risk of false positive result. However, it's no longer available recent days. We don't measure dexamethasone levels. So the low-dose dexamethasone suppression test can be done with 1 milligram overnight, whereby patient is given dexamethasone at 11 p.m. the night before and serum cortisol sent the day after at 8 or 9 in the morning. Or it can be done over 48 hours, 2 milligram over 48 hours, where patient is given 0.5 milligram every 6 hours. And you're supposed to send for serum cortisol level 6 hours from the last dose. And for both tests, the normal response is regarded as serum cortisol of less than 50 nanomole per liter can exclude Cushing syndrome. So it's a simple screening test whereby it can be done as outpatient setting. However, there is always, you can have a false positive and false negative results. So overnight dexamethasone suppression test, the serum cortisol level concentration is same for both tests. This is rather easy because you're just gonna ask patient to take 1 day before 1 dose, and it's used most frequently because the less complex and the easy nature of the test. Okay. And 48 hours low-dose dexamethasone suppression test is rather complex, but it has improved sensitivity compared to your overnight dexamethasone suppression test. Traditionally, it was known as a confirmatory test for Cushing syndrome. Endocrine Society guidelines still recommend this low-dose dexamethasone suppression test, which being done over 48 hours, as the initial screening test as opposed to 1 milligram overnight dexamethasone suppression test. So moving on, the next test that we can use is late-night salivary cortisol. The principle is based on the assumption that patients with Cushing syndrome lost the normal circadian nadir of cortisol secretion. The late night from 10 to 11 p.m. target time represents the physiologic nadir for serum cortisol level. A normal response in individuals will be a level of less than 4 nanomole per liter. In Cushing syndrome, the level will be elevated at more than 4.3 nanomole per liter. Okay, again, for late night salivary cortisol, you need to have 2 collections. So, it carries certain advantage when you are facing certain group of patients. For patients with the renal failure, so you can obtain a late night salivary cortisol because it doesn't interfere with renal function, and it can be used easily in children, and it has an impressive stability. It can be stable left alone at 1 week at room temperature, and it does not get influenced by the variation of cortisol binding globulin. However, this test has the disadvantage. You will not be able to do it in patients who are doing shift works because there will be a disruption of a normal day and night cycle. So these are various studies quoting the sensitivity and specificity of the late night salivary cortisol test. As you can see, both sensitivity and specificity goes across 90% and for the late night salivary cortisol test. So this is the diagram, I would say the most important diagram. So tabulating all the tests that I've just mentioned just now. So, and it also mentioned the sensitivity and specificity associated with certain tests that we are being utilized. As you can see, for the sensitivity, there's actually almost all the tests actually carries a sensitivity above 90%. The specificity, it drops slightly compared to the sensitivity. So late night salivary cortisol and dexamethasone suppression test carries a high sensitivity compared to urinary free cortisol. So what is the differential diagnosis? So now we have screened, we have confirmed the diagnosis of Cushing syndrome. So the next is to measure the ACTH level. It is recommended to do 2 different readings of ACTH. So it depends on which center that you are attached in, because the unit will be different. So it's very important when it comes to endocrine, we always look at the unit. So because the value changes if the unit changes. So when we look at on the right hand side here, so when the ACTH is less than 10 picogram per mil or less than 2.2 picomole per liter, this denotes a ACTH independent Cushing syndrome. So the next thing is we know this is due to adrenal. So the test of choice will be either a CT or MRI of the adrenal, and the subsequent treatment depends on what we find from the imaging. So on the left-hand side here, we have a ACTH level of more than 20 picogram per mil or more than 4.4 picomole per liter. So this denotes an ACTH-dependent Cushing syndrome. So there are some tests that we can do to differentiate ectopic source or pituitary source. So we'll come to that in a while. So when you have an ACTH and you have clearly denote this is from adrenal, pituitary, and ectopic. I mean, this is like we are just gonna differentiate whether it's an ACTH dependent or ACTH independent. So if let's say it's an ACTH independent and it denotes an adrenal lesion, so what can go wrong with the adrenal which gives rise to this Cushing syndrome? The most often it's due to adrenal adenoma, and less common will be adrenal carcinoma or bilateral macronodular hyperplasia or PPNAD. Or when you have ACTH-dependent Cushing syndrome, it can be either from pituitary, which give rise, pituitary adenoma gives rise this Cushing syndrome, which is known as Cushing disease, or the ectopic Cushing can be from tumors elsewhere. Namely, it can be a neuroendocrine tumor arising from the pancreas, thymus, bronchus, or it can be from small cell lung carcinoma. So just now I did mention about that high dose dexamethasone suppression test. So this test is being done to distinguish between Cushing disease from ectopic ACTH secreting tumor. The theory behind it is the Cushing disease tend to be semi-autonomous. They respond to dexamethasone, very high dose dexamethasone. In high dose dexamethasone suppression test, we use 16 milligram of dexamethasone. So, and this Cushing disease did response to, it still has this response to this high dose dexamethasone. And what we will be able to see, the ACTH production reduces more than 50%. And it will be in ACTH from ectopic sources, there will be fail to respond to this high dose test. But this is not always true. Even some tumor arising from the neuroendocrine tumors arising from certain organs actually can show similar response as per Cushing disease. So before we see whether this is, when we talk about ACTH-dependent Cushing syndrome, whether this is Cushing disease or ectopic ACTH syndrome, there are a few clues that we can gather as we clerk the patient, examine the patient, and certain investigation will tell us whether this is Cushing disease or ectopic ACTH syndrome. So the onset being in Cushing disease is rather a gradual onset and progressive, and is insidious and tend to run a several years course. As opposed to ectopic, the onset is rather sudden or abrupt, and the duration is usually less than 2 years. And patient will present with florid Cushing's or rapidly progressive Cushing's. And Cushing disease tend to be more common in females, and there is no sex predilection when it comes to ectopic. Hypokalemia is noted to be more common when it comes to ectopic, and all the biochemical testing, the random serum cortisol, urinary free cortisol, it will be markedly elevated in ectopic ACTH syndrome rather than in Cushing disease. Again, your ACTH will be markedly elevated when it comes to ectopic ACTH syndrome. And the MRI in Cushing disease will be able to see a tumor, and in ectopic ACTH, you can have some incidentaloma as well. And about the dexamethasone suppression test, you can get some suppression with Cushing disease, and you will fail to show any suppression, or it will be for the CRH. We are not going to talk about CRH. In Malaysia, we don't have CRH. We'll talk about IPSS in Landi later. Okay, so next, following the algorithm, we are measuring the ACTH. When it's low, then you know it is normal or high. So the next step will be getting a pituitary adenoma. Okay, so most often the time, when you pick up a tumor of more than 6 mm, you can presume this is actually due to Cushing disease. But the problem is when you have small tumors, or worse still, when the MRI can't able to pick up any tumors. So when for the localization per se, we will proceed with MRI. So we only proceed with anatomical imaging in Malaysia, and MRI is the imaging method of choice. Most lesions are very small, so it really challenges the radiologist to pick up any adenomas that is visible. And of course, with the technical refinement, it may enhance the detection. However, 1/3 of patients still remain negative imaging. And tumor size does not necessarily correlate with the degree of hypercortisolism in Cushing disease. A pituitary adenoma of more than 6 mm can be presumed this is due to Cushing disease, meaning that this is the source that producing your Cushing syndrome. And pathologic analysis is necessary, meaning that after you do a surgery, it's important for you to look at the HPE to make sure that this is a ACTH producing adenoma, because about 15 to 20% in the autopsy studies shows that it's rather an incidentaloma. So this is a very good systemic review just published in 2023, looking at the MRI for Cushing disease. They are looked at 57 studies, rather a large cohort of patients, about 5,000 over. And what they found is overall sensitivity for tumor detection is about 73%. And in microadenoma, it carries about 70%. So what is important? Why is it that we need to fine tune? I mean, we need to try our level best to detect an adenoma in the MRI, because this is translated in long-term remission. This it says that there is an increase 2.6-fold increase in remission rate when we can actually pick up the tumor pre-operatively compared to patients with MRI negative cases. So what are the future directions in imaging? So when you couple anatomical imaging with the molecular PET imaging with enhanced data analysis, we can actually pick up more tumors. So these are some traces that being used for molecular or functional imaging. So mind you, in Malaysia, we don't have this. We only use anatomical imaging, but Western countries actually start to utilize this molecular or functional imaging for better detection. So moving on with bilateral IPSS. Okay, so this is an inferior petrosal sinus sampling. This is a gold standard when you want to distinguish Cushing disease from ectopic. From my previous presentation, when I mentioned about the high-dose dexamethasone suppression test, there is a table comparing what are the clinical features. All this can actually give you a clue, but the gold standard is still IPSS. You are supposed to do IPSS only after confirming a biochemical test says this is an ACTH-dependent Cushing syndrome. And when you do the imaging, and the imaging is inconclusive, meaning the MRI failed to detect a tumor of more than 6 mm. Okay, on the day when we do IPSS, so there are certain requirements. So if you pre-treated patients with certain medical therapy, you're supposed to off this for at least 1 week prior to the procedure. And prior to conducting the procedure, we need to ensure the patient is still in the active phase of Cushing disease. So how is it being done? It's actually done by interventional radiologists. And mind you, not all centers are capable of doing this. Only very selected centers can actually perform IPSS. It's a very invasive procedure. So what happens is they will be cannulating the femoral vein and advancing the catheter all the way to inferior petrosal sinus. So there will be one in the right side, there will be one on the left side. So what happens is there will be, what are we looking at? So basically we want to measure the ACTH from the central source, which is your IPS, and from both right and left, as well as from the periphery. And we also will send blood for prolactin level as well. And again, although it's such an invasive test and it's a gold standard, again, it is not good in tumor lateralization. From IPSS, you can't say this tumor is arising from the right or left side of the pituitary gland. So how do we interpret IPSS? So in Cushing disease, we are looking the ACTH gradient. So how's the test done is we actually do the test basal, which is your 0 minute. After that, the patient will be given stimulation. If the countries with CRH, they'll be using CRH. We don't have CRH, so we use desmopressin. So there will be blood drawn at 3 minutes, 5 minutes, 10 minutes post desmopressin test. So what happens is we are looking at the ACTH gradient from central to the periphery before the stimulation as well as after the stimulation. And the values of interest will be more than or equals to 2 when it comes to unstimulated, and post-stimulation we are looking at a level of 3 or more. If, let's say, there is a failure to show a significant ratio, meaning that you don't see any obvious gradient from central to periphery, then you have to ask yourself, there are two possibilities, whether is this a failed cannulation or are you dealing with ectopic source of ACTH? So the next is we look at the prolactin level. So prolactin basically is a surrogate marker to which will tell you whether there was a successful cannulation or not. So a ratio of more than 1.8 shows successful cannulation. So again, if you have a successful cannulation and there is a failure of a gradient, then you know this is a ectopic Cushing syndrome. So just now, earlier, I mentioned it's mandatory for us to establish a biochemically confirmed ACTH-dependent Cushing syndrome before performing an IPSS. Because if you do an IPSS, cut short all the screening tests, even in a normal individual, you can get the same gradient as per Cushing disease. So before we move on to management, let's talk about the Cushing syndrome. As mentioned earlier, Cushing syndrome is a multi-organ disease. So it has various complications at the various areas of body. It can cause hypertension, diabetes. Patient can have osteoporosis. Worst case scenario, they can present with fracture. They are high risk for venous thromboembolism, and they can come with a frequent or fulminant infections. So when it comes to Cushing disease, the mortality is about 5.5-fold higher, and they have increased morbidity. So they can have various morbidities as per illustrated here, and they have a significant impact health-related quality of life. And most often, the patients actually die. The mortality is due to cardiovascular complications. So they can have other complications as well, from hematological, renal disease, or they can even have neurocognitive impairment. So we are going to talk about the management in Cushing disease. So first is pituitary surgery. So they will have a multi-modalities of therapy. First will be the pituitary surgery. When you have a functioning or secretory tumor of a pituitary, surgical option is the mainstay of therapy, except for prolactinoma. So in all the other functioning tumor, the first therapy is your pituitary surgery. Again, followed by medical therapy. So there are various drugs groups that you can utilize for the medical therapy. Then there comes pituitary radiation, and the last resort will be bilateral adenylectomy. So pituitary surgery, your TSS or trisphenodal surgery, is the mainstay of treatment. So, and the remission is defined as a serum cortisol of less than 55 nanomole per liter on post-operative serum cortisol level. And some studies might quote a level of 138 nanomole per liter. So patient who actually goes into remission following surgery often requires a glucocorticoid replacement until there is a HPA axis recovery. But in those patients with a mild disease, they might not have a marked post-operative hypocortisolism. The complications arising from the pituitary surgery is rather low, with the mortality rate is less than 1%. So although when you do a post-operative serum cortisol and it's low and is defined remission, this actually, the low cortisol level does not predict recurrence. So these are various studies over the decades looking at the outcome of surgery. So the percentage varies across. So now come, let's look at this, the last 1 decade. So when you have a patient with Cushing syndrome and you are sending the patient to surgeon for the surgery, not all the patients will be cured, or in other terms, they don't go into remission. When your patient has microadenoma, the remission rate falls below, ranges between 70 to 90%. And this rate drops to 60 to 65% when the patient has macroadenoma. And if, let's say, post-surgery, they have recurrence or persistent disease, and you were to subject them for another surgery, the remission rate is rather low. So what are some key determinants of surgical outcomes in pituitary surgery? Of course, we have a patient factor. So when your patient has a severe hypocortisolism with multiple comorbidities and complications, then the surgical outcome might not be as favorable as those with a mild disease. When you are dealing with an extensive or such a large tumor or invasive tumor encasing the IJC or invading the cavernous sinuses, then you know this kind of patient, the chances of them going into remission is rather low. And lack of imaging, picking up the tumor prior to the surgery plays an important role as well. Of course, finally, it's all in the hand of the surgeon. Ideally, the patient should be referred to high-volume pituitary surgeon in the center of excellence. If the patient falls into a good surgeon, then the mortality and the complication can be minimized and thus can improve the surgical outcomes. So let's move on to other modalities, which is the medical therapy in Cushing disease. So just now I said surgery is the mainstay. However, it's not the only therapy. Sometimes you're planning for surgery, but the surgery might be delayed, or your patient unable to go for the surgery because of certain contraindication, or the patient goes for surgery but is unsuccessful. Then this group of patients, you can consider medical therapy as adjunct. So there are various groups here, like, namely adrenal siderogenesis inhibitor. This is the common drugs that you use, namely ketoconazole, metilirapone, atomidate, oscillodostat, mitotine. So these are the common drugs some of you may be familiar with in your day-to-day practice. And if, let's say, we want to target the therapy for the pituitary tumor, then we can either consider a dopamine receptor agonist or somatostatin receptor ligands. Or in the event that we can't block any of this, or we only want to block at the peripheral tissue level, then you may consider a glucocorticoid receptor blocker. So medical therapy is aimed to normalize cortisol concentration. The choice of the therapy, it depends on the clinical scenario of the patient, severity of the hypercortisolism, the treatment availability, and of course, the cost. Adrenal siderogenesis inhibitors are the first line and most readily available and is effective. For mild diseases, we may target the adrenal siderogenesis inhibitor using ketoconazole, metilirapone. And for those with a mild to moderate disease with some residual pituitary tumor, we may go for a pituitary targeted therapy with a cabergoline or pasireotide. In severe hypercortisolism, we may use a combination therapy with the 2 siderogenesis inhibitor or more. So basically, we just want to give patient a cocktail of therapy. So this is just a busy slides. I just listed down all the agents that we have here, and what we use in regular practice is good to know, but I'm not gonna bore you with all this. It's the extra information. Let's talk about the radiotherapy when Cushing disease. It's primarily used as adjunct therapy for persistent or those patients with recurrent disease. Two-thirds achieve biochemical remission during the years after the treatment with a conventional external beam radiotherapy. So nowadays, the famous will be the stereotactic radiosurgery. It shows a higher biochemical remission rate. But stereotactic radiosurgery, although it's gaining fame, but there are certain things like you can utilize this as a primary therapy in those patients who refuses surgery. But although the stereotactic radiotherapy, it probably offers a better, those patients who can't go for surgery, it offers a better result. But there are certain things that you must be look into before subjecting patient, especially when the tumor location with your optic chiasm. Okay, and the common side effects of radiotherapy will be hypopituitarism, which can happen in 1/4 to half of your patients. So the last resort will be your bilateral adrenalectomy. So offers immediate control of cortisol excess in patients with persistent or recurrent Cushing disease. It's only considered in a selected patient. Your patient selection must be very, very we must really make sure there's nothing else before we resulting patient for bilateral adrenalectomy, because you're gonna render patient lifelong hypocortisol. Patient will be dependent on glucocorticoid and mineralocorticoid replacement therapy lifelong. And of course, corticotroph tumor progression, or previously known as a Nelson tumor after your bilateral adrenalectomy, is a concern. So again, this is just a chart to highlight whatever that I've said earlier. So when you have patients with Cushing disease, you can pre-treat with the medical therapy while waiting for surgery. Then you're supposed to send for your patient for surgery if there is no contraindication. If they go into remission along the way, after many years or after months, they can still develop recurrence. If your patient following pituitary surgery, they have persistent disease, then you can have other modalities of therapy, whether you subject them again for surgery or considering medical therapy or radiation therapy. Or these options can be considered in those patients. Surgery is not an option as well. So the last resort will be bilateral adrenalectomy. So going back to the case, so I'm reaching to the last part of my presentation. So just a brief overview on the case again. So this is a Madam A, the 69-year-old lady who came to me for the hypokalemia. So this was the biochemical testing, which shows there is a failure of suppression. So your ODST was 810 nanomole per liter. There is a failed suppression. 24-hour urine-free cortisol was 4 times upper limit of normal. Again, there was no suppression noted for low-dose dexamethasone suppression test. Proceeded with the ACTH, which shows a normal, inappropriate normal. This is a picomole per liter, so this is an elevated ACTH level. And the patient's diagnosis at this juncture will be ACTH-dependent Cushing syndrome. It can be arising from your pituitary or it can come from ectopic source. So the next step is proceeding with the MRI pituitary. So what we found is a small nodule hypoadherence lesion, which measures rather small. So this is like a 4 mm. So if the nodule is more than 6 mm, then we can presume this is a Cushing disease and send the patient for surgery. However, since this is a small tumor, the next is to proceed with IPSS, which is the gold standard. So what we are looking at, this is the 0 minute of IPSS level reading before the stimulation with desmopressin. This is 5 minutes and 10 minutes results. So again, the ACTH, looking at the periphery as well as the center on the right and the left. So when I've already tabulated the ratio for y'all, what you can see is the basal, if the ratio from the right to the periphery is 1.1, so it's low. But look at the left, it is high, it's more than 2. And for the 5 and 10 minutes following stimulation, the ratio in all the 4 tests, it is high, more than 3. So this is actually in keeping with Cushing disease. So she's planned for TSS and she's awaiting date for her surgery. Meanwhile, she was pre-treated with steroidogenesis inhibitor. I've started her on ketoconazole 200 milligram twice daily with the latest AM cortisol of 443. Her DM control improved, A1C dropped from 11% to 7%, hypokalemia resolved, the symptoms, all the symptoms resolved. She has no more proximal muscle weakness. She can walk. She's very cheerful. No more depressed, moody. Okay, that's the end of the first case. So she has pituitary Cushing's, okay, or your ACTH dependent pituitary Cushing, which is your Cushing disease. So the second case, which is the young girl who came with a secondary amenorrhea with some features of Cushing disease, Cushing syndrome, sorry. So this is the biochemical testing in the young girl of 16 years old. She failed to suppress ODST and as well as low-dose dexamethasone suppression test. First, your 24-hour urine cortisol was just 2 times upper limit of normal. When we look back, it's because of the inadequate urine volume. She rather just collected half day. So when the test was repeated, she actually had more than 4 times upper limit of normal of your urinary free cortisol. Proceeded with ACTH, which is 1.1, which is low. So this is denoting an ACTH independent Cushing syndrome. Subsequently, the CT was imaged, which showed a right adrenal lesion, which is suggestive of an adenoma. So she underwent a right adrenalectomy. When reviewed her in clinic, she had significant weight loss following the surgery. All her symptoms resolved. She no longer has the deepening of voice. There was no hirsutism. Her menses was regular, and she was in a remission for her both diabetes and hypertension without any treatment. And the biochemical testing showed complete remission. Her ODST was suppressed, and a 24-hour urine-free cortisol was not raised. So this is the end of the second case. So moving on to the third case, which is the Miss CS with 30 years old came in for suspected Cushing syndrome. So she failed to suppress ODST as well as low-dose dexamethasone suppression test. Her 24-hour urine-free cortisol rather very high, 6 times upper limit of normal. Her CCTH level is very much high. And from here, you can have some clue. Probably you are dealing with ectopic ACTH, but you can't decide at this juncture. What you can come up with is an ACTH-dependent Cushing syndrome. It's possible Cushing disease, but it's possible Cushing syndrome as well. And I would like to remind you again, this patient rather presented very abrupt onset, very short duration of time, just months. Proceeded with a high-dose dexamethasone suppression test, which failed to suppress. Proceeded with an MRI, which is normal. Subsequently, she had all the CT of adrenal thorax, which noted to have an anterior mediastinal tumor measuring 5 and 4 times 2 cm. So this patient actually has an ectopic Cushing syndrome secondary to thymic tumor. She underwent thymic resection, and unfortunately, her Cushing syndrome relapsed after 3 years with the tumor recurrence with multiple metastases to supraclavicular lymph node pelvic region, and she underwent multiple surgeries subsequently and finally resorted to bilateral adrenalectomy. And right now, she's on lifelong glucocorticoid and mineralocorticoid replacement therapy. That's the end of my presentation. Just some take-home messages before I end. Cushing syndrome significantly increases morbidity and mortality, and early detection and appropriate intervention are the critical features when it comes to management. So diagnosis can be challenging, especially in mild disease, and there is no one single test is 100% accurate. And you should know there are many assays with variable performance. Several concordant tests may be necessary to confirm the diagnosis. The primary goal is you want to establish a hormonal remission. Surgery is the preferred choice when it comes to Cushing disease. Persistent disease will require adjunctive multimodal treatments from medical therapy, radiotherapy, or bilateral adrenalectomy. So management of Cushing disease is rather difficult and requires a multidisciplinary approach. That is the end of my presentation. Thank you. Any questions?
Thank you, Dr. Devika. I think you have extensively covered the whole chapter or whole textbook on Cushing's syndrome and Cushing's disease. So to the participants of the webinar today, if you have any question, do put it in the Q&A box, and Dr. Devika will answer them shortly. Meanwhile, while waiting for the questions, Dr. Devika, we're often told by experts that if you have never misdiagnosed Cushing's, means you have not seen enough Cushing, because our professors used to tell us that because it is very difficult. Cushing's is a very difficult condition to diagnose and to manage. And we know that exogenous Cushing, which is caused by taking steroid, that is very common, but endogenous Cushing itself is very rare. And a lot of our Cushing's patients have diabetes, hypertension. So if you are sitting in a diabetes clinic, day-to-day diabetes clinic, what are the important clues to look out for to trigger in your mind that the patient may have Cushing?
As I illustrated earlier, most of the symptoms are overlapping between a normal obesity with Cushing disease or Cushing syndrome. So it's often that we miss the first time as we see the patient, then it actually might ring a bell like probably this patient has Cushing disease. So all this, when you are dealing with the patient, you must have high index of suspicion, especially when patient presents with discriminatory features. So then you must have even a slightest clue, like they can just present with something just doesn't fit into the picture well. Then you must ask yourself, are you dealing with Cushing? As it implies that it's very difficult and it's very insidious, and they don't come in with a florid Cushing from the very beginning. So they actually progresses over the time. The initial might be very subtle features. As time goes by, it will be a prominent features. But if let's say we say somebody have already examined the patient at the beginning and now we stop looking at the patient as a whole, we may miss Cushing's.
Yeah, and I think the other clue is if they have had good control of the diabetes or hypertension for a long period of time and suddenly it becomes uncontrolled, we also need to think whether they've developed some other secondary causes like Cushing's. The other thing I want to ask is as a MO previously, I used to be very confused with all these dynamic tests that we do. When do you do synectin tests? When do we do overnight dexamethasone suppression tests? Is there any simple way to remember all these tests that we do?
When you deal with exogenous steroids, so you get a history, this is an exogenous steroid, the next step will be getting an AM cortisol. And if it's not rather very low, like less than 140, you proceed with synectin tests. Okay, so when you have excluded exogenous Cushing's, and this is you are dealing with the endogenous Cushing, this is where we have to utilize all the screening tool that what I have mentioned earlier. So don't get confused. In exogenous Cushing, what we are looking for is hypocortisolism. Hence, we measure AM cortisol followed by a synectin test. In the endogenous Cushing, we are looking for a Cushing state, hypercortisolism.
Yeah, thank you for making that clearer. And just a reminder to participants, if you have any question, we do have 1 or 2 more minutes for question. Do type it in the Q&A box. Otherwise, just one more last question for myself. When should we, as a general physician or as a MO in the medical clinic, when should we refer a suspected Cushing's to an endocrinologist? We do the test first, then we refer, or once we suspect, we refer?
It depends whether you are dealing with a mild disease. If there is a mild disease and the likelihood of Cushing syndrome is low, you can carry out the screening test in your center. If that test is available, like 24-hour urinary free cortisol, you can do. But if let's say it's limited, you don't have access to a certain test, or the high likelihood is very high, you're dealing with a moderate to severe Cushing, it's better to refer them early. Or when you already have complications.
Okay. I think yeah, it's already 4 p.m. That's all the time that we have today. Thank you, Dr. Devika, for all your sharing on Cushing's disease and Cushing syndrome. I'm sure all the participants have learned a lot. I certainly have. And yeah, Dr. Kelvin, back to you.
Yep. Okay. Thank you, Dr. Tong, for sharing the session, and Dr. Devika for the wonderful talk. Thank you, everyone, for participating in today's webinar. We will see you again next week. Goodbye.
Thank you, Dr. Tong. Thank you, Dr.
Thank you. Bye.